Hello, and thank you for joining us for today's episode of A Cancer Conversation with the Georgia Cancer Center at Augusta University. In this episode, we will be sharing information about various topics related to head and neck cancer. April is Head and Neck Cancer Awareness Month, as well as Esophageal Cancer Awareness Month. Joining me for the first segment of today's episode conversation is Dr. Ken Byrd. Dr. Byrd is a head and neck surgical oncologist and a member of the otolaryngology team at the Georgia Cancer Center and Augusta University Health. The first part of our conversation is going to focus on the steps we can all take to catch head and neck cancer early, sooner rather than later. And then the second part is going to focus on how your diet and nutrition needs might change once you have a head and neck cancer diagnosis. Dr. Byrd, thank you for joining me to get today's conversation started.
Yeah, thanks for having me.
So before we start talking about head and neck cancer and the different types, I want to learn a little bit more about you. How did you get started in this career? What led you here?
Sure. I think like a lot of medical students who end up in otolaryngology, I was initially intrigued by the anatomy. That's one of the first things that medical students get exposed to in kind of a traditional curriculum, and just really like that a lot of the nerves and arteries are close together. A lot of the senses are also clustered in that area. And I was exposed early to some of the otolaryngology residents where I was, and kind of got looped in that way. So I figured out that otolaryngology is where I wanted to start it, and really enjoyed all of otolaryngology, or ENT is it's commonly called.
Yeah.
There's a lot of different parts of that: speech and swallowing, hearing, and allergy. But head and neck cancer is part of that. As we talk about head and neck surgery as part of being part of otolaryngology. And I think that it's really just that you can really make a difference in someone's life when you take care of them, and it can be a challenge, and so that's really, I think, what got me into it.
Gotcha. Yeah, ENT, ear, nose, and throat. You get to deal with a lot of the senses. The smell, the taste, the hearing, the sight, like kind of all of it there.
Exactly.
How long have you worked at the Georgia Cancer Center and Augusta University Health?
So almost 8 years. I joined in 2014 after I finished my fellowship in Pittsburgh.
Okay. What made you choose Augusta University Health and the Cancer Center?
Well, I grew up not far away from here in South Carolina, near Columbia and Lexington.
Okay.
And I went to MUSC for medical school and residency, and so I was familiar with the program here and familiar with Augusta, having had some friends that were from here and having been to the Masters a few times.
Okay.
My wife and I are both in medicine, and we were both looking for jobs where we had the opportunity to teach residents, but focus within our own subspecialties. And it happened that they needed a pediatric otolaryngologist and a head and neck surgeon, so it worked out well, and we've been happy here since.
Well, we are glad to have you here. Talk a little bit about what it means to you to be part of a head and neck cancer patient's journey during their treatment process.
Sure. Well, the treatment for head and neck cancers is not always surgical, but surgery is always a part of the workup because of the need to biopsy the lesion and get tissue and confirm that it's cancerous. So, sometimes I start with the patient with an abnormal lump or ulcer or a plaque in the mouth or throat. Sometimes another doctor's already done the biopsy or done the workup. And so the head and neck surgeons are often sort of the funnel that get patients into the system here. So we start with that, and with a biopsy and then imaging to determine the extent of disease. Is it localized to the mouth or throat or voice box, or is it spread to the lymph nodes? Has it spread anywhere else in the body? And then once we do that, we then have a multidisciplinary tumor board meeting, which we do every Thursday, where we have representatives from surgical oncology, head and neck surgery, as well as radiation oncology and medical oncology, and then multiple other subspecialties like radiology and pathology, speech and language pathology, and we then will talk about the case and go over the staging system according to the AJCC staging system, and then we talk about the National Comprehensive Cancer Network guidelines, and we come up with a treatment recommendation for patients. So we're sort of the gateway to that, and then for patients who stay with us for surgery, then we get them through surgery, get them through their hospital stay, help them recover, afterward, help them get home or to a rehab facility if needed, and help get them recovered and then on to whatever additional treatment they may need.
Okay.
And then usually the otolaryngologist head and neck surgeon is the person, or at least one of the people that will follow the patients for at least up to 5 years to make sure that, that they're healing well and recovering, that the speech and swallowing and quality of life are as good as possible, and to make sure that the cancer doesn't come back.
And what does it mean to you to know that you're going to be there for 5 more years? I mean, that's a long time to kind of be with that patient and work with that patient.
Yeah, and I think that's one reason that I chose what I do, because in some surgical subspecialties, you may fix a problem and then not see that patient again once you're sure that they've recovered. For example, I've had ankle surgery back from my basketball days, and I don't think I saw my orthopedist, outside of recovering from that surgery. But
okay.
I think that's one rewarding thing in head and neck surgery, is that we get to develop a relationship with the patients, and they come to rely on us and trust us, and you develop a more personal relationship.
So April is Head and Neck Cancer Awareness Month. Can you share some information for those watching or listening to this episode about the different kinds of head and neck cancer that you and your team treat here at the Georgia Cancer Center?
Sure. Well, head and neck is confusing for some people, because I'll get often asked in the elevator by a patient what I do, and I'll say head and neck surgery, and they'll say, "Oh, well, I have spine problems," and really we're treating kind of everything outside of the spine and outside of this, outside of the skull, not brain cancers and not spinal cord, and not spine injuries. So the most common historical head and neck cancer, aside from skin cancer, we take care of skin cancers in the head and neck region, would be mouth cancer. So tongue cancer or floor of mouth cancer, cancer on the inside of the cheek or on the palate. The second most common historical type of cancer in the head and neck region would be laryngeal cancer, or cancer of the voice box. And so that primarily affects the vocal cords, but less commonly it can affect the area above or below the vocal cords as well. Those cancers are most commonly associated with tobacco use for a number of years. And we've actually seen that decline on a population basis since people have learned that smoking is not healthy and are smoking less often.
That's good news to hear.
Yeah. What we've seen increasingly, though, is throat cancers or pharyngeal cancers. And so that's broken down into 3 areas. The nasopharynx is the area kind of behind the nasal cavity and above the soft palate. The oropharynx is the tonsils and the base of the tongue primarily, as well as the soft palate. And then the hypopharynx is the entrance into the esophagus. Oropharyngeal cancers are what we're seeing a real increase in, and that's related to the human papillomavirus, which is the same virus that causes cervical cancer in women. It can cause cancers of the tonsils and the tongue base in men and women.
Okay. And so this is probably a good time to talk a little bit about the HPV vaccine. We did a podcast episode interview with Dr. Robert Higgins about cervical cancer, and we talked a little bit about HPV, but men and women can both get the HPV vaccine starting in their teen years.
Right. And it was initially approved, as you said, for prevention of cervical cancer, but as they realized that the same subtypes of virus cause throat cancer, they've expanded the indications to young men, and men actually, I believe, up to age 45 now. We don't know everything about HPV-related throat cancer, of course. We do know that it's strongly associated with sexual history, probably exposure in the teens or early 20s, and then may go dormant after chronic infection, and then appear as a lump in the throat or a lump in the neck or a lesion in the throat, usually between the ages of 40 and 60, although some older people can get it as well. So, I know that, and you probably covered this in your other podcast, but people have a lot of, I think parents sometimes have a lot of apprehension about talking to their children about sex, understandably, and they may feel that giving this vaccine is giving them permission to do something. And I have this conversation often with patients, because they're in their 40s or 50s, and they have kids, and they ask me about it, and I say, well, you don't think about it as in terms of giving permission for sexual activity as much as that this is a cancer vaccine, pure and simple, for cervical cancer, other anogenital cancers, and also for head and neck cancer. And we don't know how it's transmitted. I have patients who have HPV-related cancers who have been with the same partner since they were in high school, and they haven't been exposed to anybody else. So there may be other ways to get it. And also, when we're talking about children, they may be responsible for their own behavior, but they may, end up with someone who made different choices. And so I encourage everyone of that age to at least consider getting the vaccine from a medical basis. I think that we don't have data demonstrating that it decreases head and neck cancers because we don't have a precursor lesion or a test like a pap smear to prove that it's decreasing. But I believe that in 10 or 20 years, what we'll see is that will also decrease in incidence due to more people getting vaccinated and also group immunity.
So definitely important to encourage parents, moms and dads, to talk with their child's pediatrician or primary care provider about the HPV vaccine, and even how to have conversations with their children about that sort of topic.
Yeah, I think that anything that you can do to prevent cancer is going to be better than anything we can do to treat cancer. So it's, I think, important to use all the tools we have to prevent it.
One of the aspects of head and neck cancer that we would like to share with our watchers and those listening is potential screening opportunities. And I know that we try to do a screening event every year, but with the COVID-19 pandemic, that has not been possible here in the last couple of years. But what are some of the things that can a primary care provider do a head and neck cancer exam or that sort of thing? Or what sort of information can you give those people watching about that?
Sure. Yeah, we've always enjoyed doing our screening events, and unfortunately, because of COVID and this year we were not able to get it scheduled. I think that as we've seen the CDC restrictions relax, and we probably will start having it again next year, but certainly a family practitioner or even a dentist can do screening. And when we do these screenings, we're not using fiber optic scopes or anything like that. We're really just doing an exam of the neck and the thyroid, as well as the mouth, and looking at the front of the nose, looking at the tonsils. They can do all these things. They can look around for abnormal colorations, ulcerations, areas that are firm by palpation, areas that may bleed. Patients may have pain in those areas. The other thing in the neck is just to palpate and see if there's any abnormal firm round areas or enlarged lymph nodes in the neck. And then when we talk about head and neck cancers, that also does include thyroid cancers, and palpating the thyroid is another thing that they can do. But my dentist, who is a friend of mine from college, and then he was in dental school when I was in medical school, that I still go see in Columbia, he actually, every time I see him, does an oral cavity exam on me looking for head and neck cancers, even though he knows what I do.
Yeah.
So I strongly think that that dentists can really be on the front line and help catch these lesions early. And some of the education that I've done giving talks there is to encourage them to look beyond, just the mouth, but also to look at the tonsils and see if there's anything abnormal that they can view, with a mirror or just, with a light at the backside of the throat.
Okay. So you talked a little bit about tobacco use being a risk factor. Are there any other, and HPV, are there any other risk factors we should be aware of when it comes to developing different forms of head and neck cancer?
Sure. I mean, we know that radiation exposure through, sometimes patients are treated with radiation for other cancers, or, they may have been exposed to radiation by being in the armed services or work in an area where there's radiation exposure. Those can be related to thyroid cancers and other sarcomas. In terms of the more common head and neck cancers, alcohol is a risk factor for head and neck cancers also, not as strongly as the others, but alcohol with heavy tobacco use leads to a much higher risk of cancer.
Okay.
There are, other occupational exposures, burns can lead to squamous cell carcinomas, and then I guess when I talk about occupational exposures, things like wood dust and chemicals can lead to some of the more unusual tumors that we see in the head and neck.
Okay. Good.
Also, I guess I'll mention poor oral hygiene, so having teeth that need to be seen in service by a dentist, or poorly fitting dentures. Anything really that causes chronic irritation over a long period of time in the mouth can also lead to mouth cancers. And I have a subset of patients who are older women who've never been smokers that sometimes develop oral cancers for this reason.
Okay. All right. What sort of symptoms or signs should someone be looking for? We talked a little about lumps and things of that nature. What sort of signs or symptoms should we be on the lookout for with head and neck cancers?
Well, you mentioned the senses, so anything that disrupts the senses in the head and neck area. So you may notice, a change in taste or a change in hearing, double vision, abnormal sensation, pain. Those can all be things that are a little more subtle. More commonly, I guess, if you're talking about mouth cancers, you're going to a lesion that's discolored or growing, an ulcer that doesn't go away after about 2 weeks. People can get aphthous ulcers, or they may get bite trauma, but really it should be better after about 2 weeks. Ear pain or throat pain. Ear pain is often referred from some of the same nerves that go to the ear, also run through the throat. And so throat pain is a common symptom for cancers of the pharynx or throat. Bleeding lesions, but really anything abnormal, that something, a new sensation or a new change, or a new mass that's been there for longer than about 2 weeks, it should be evaluated.
Okay. And if someone does find themselves diagnosed with head and neck cancer, talk a little bit about what it's like working with you and the team. We talked a little bit earlier, but talk a little bit about what your approach is to working with cancer patients.
Well, we try to make sure that they feel very well supported, and one of the important things I think that the Cancer Center has is nurse navigators, and they do, as their title suggests, they help patients navigate through their cancer care. Patients may not be with the surgeon; they may be in radiation or they may be in recovery, but that's a kind of a point of contact for the patients, and they get to know the navigators very well. So they are often the first person that reaches out to them to help get them in for evaluation. We have residents that help take care of the patients. We have nurse practitioners and physician's assistants. So I think that the key is that we try to make them feel that they're well supported and well taken care of. I think some of the other things that the Cancer Center has to offer, for example, psychosocial oncology is a great service that we have, where patients who are suffering from anxiety or depression or trouble sleeping that is related specifically to their cancer diagnosis or treatment, that's a great service with therapy, and they make sometimes recommendations for medications that can help patients cope with that. Because I think it's important that these are therapists that they focus on cancer patients, so that they're not also seeing patients who have other psychiatric disorders. It's specifically because of the cancer diagnosis, and sometimes especially with male patients, they're a little more willing to see someone like that.
Okay.
They may fear a stigma of seeing a therapist. Men can be, we all can be, as you know, can be
yes,
stubborn, but sometimes they're willing to see a therapist if it's someone specific for taking care of cancer patients.
And do you find yourself referring a large number or a good number of your patients? Because I imagine some types of head and neck cancer and some surgical options may leave people feeling with depression or anxiety or things of that nature.
Yeah, I think a good number of patients we refer to them, and I think that it really comes down to the type of treatment they have. And patients who have advanced cancers and require heavy treatment, it can be very, it can take an emotional and psychiatric toll on them. As I said, I had ankle surgery and found myself getting depressed because I couldn't do my usual activities. And so you can imagine that someone undergoing cancer treatment who is not able to eat the things they want to because of either trouble swallowing or because of the treatment effects, and looks different and feels tired from treatment, that they would really need some help sometimes.
Okay. Can you talk a little bit more in detail about some of the treatment options for patients depending on the kind of cancer and the stage of the cancer, which of course is why it's important to catch it early?
Sure. Well, in general, if we're talking about the whole head and neck region, which is, again, a bunch of different subsites and types of tumors, we will break the staging down into overall 1 through 4 stage. And in general, patients who have stage 1 or 2 they're eligible to be treated with one single modality. So that will be surgery or radiation. And patients who have advanced disease may need surgery followed by radiation, possibly with chemotherapy, or chemotherapy and radiation. In most subsites, patients get a choice between the two. For oral cavity cancer, again, that's the tongue, floor of mouth, the cheek mucosa, we typically treat those with surgery up front because there's a lot of side effects to treating that area with radiation because of the teeth. The mandible dose has to be very high. It's got significant side effects, and it can also cause a significant amount of damage to the bony structures of the face. So those patients typically will be treated with surgery, which involves removal of the tumor and then removal of the lymph nodes in the neck, and then depending on the site and how large it is, they may require reconstruction with the free tissue transfer. For cancers of the throat or the voice box or the pharynx or larynx, including the oropharyngeal cancers that are related to HPV, those patients are often given a choice between surgical therapy and radiation-based therapy. When we're talking about, again, the oropharyngeal cancers, if we're talking about surgical treatment, we're currently using robotic surgery or transoral laser surgery to remove that. And what that is going through the mouth and then using robotic technology to shrink our large hands and instruments down, so we're able to do precise surgery in a tighter space without having to disrupt normal structures, without having to split the jawbone to get there or to make a big external incision. And then the alternative would be to treat those with radiation-based therapies. And we know that in both the pharynx and the larynx, in general, the outcomes are about the same, that meaning the cure rate is going to be the same. And what we're trying to choose is based on patient preferences, whether, some people are very anti-surgery or very pro-surgery, but also we're trying to cut down on the number of side effects that patients may have in the long term. So that's where the tumor board is really important, and we talk about specifics of each patient, which may make them a better candidate for one therapy or another. But often patients will have a choice, that if they come in, for example, with a T1N1 tonsil cancer, then they would be a good candidate for transoral robotic surgery and a neck dissection, or they would be a good candidate for radiation alone. And so we talk about the pros and cons, and we let the patients decide.
Okay. All right. Well, Dr. Byrd, this has been very informative, very educational. Thank you so much for joining me today. In our next segment, we'll actually be introducing those watching and listening to our nurse navigators. We're going to talk with them, as well as dietitian Sarah Deen, about our nurse navigator program and how diet and nutrition play a role. So thank you for joining me today, and we'll see you in just a minute.
Thanks for having me.
And we're back for this episode of A Cancer Conversation with the Georgia Cancer Center. Today's topic is head and neck cancer. And in this segment, we're going to transition just a little bit. We talked with Dr. Byrd about some of the general head and neck cancer information, educational information that we wanted to share. But now we're going to focus a little more on diet, nutrition, and head and neck cancer. So joining me now is Sarah Deen, Barb Carter, and LaJuana Kennedy. Barb and LaJuana are the nurse navigators for the head and neck cancer team, which Dr. Byrd is a part of. And Sarah is a member of the Georgia Cancer Center's dietitian team. So thank you all for joining me for this segment.
Thank you for having us.
First, Barb and LaJuana, let's talk a little bit about you, both of you. How long have you two been working at the Georgia Cancer Center?
I came in 2012, and after 4 years retired, and then came back in 2018, so 7 years total.
Okay.
I've been here.
So you retired, but then you came back, huh?
That's right.
Just enjoyed working with the patients and working with the teams?
Exactly the reason.
All right. And LaJuana, what about you?
I'm fairly new to the Cancer Center.
Well, welcome.
Thank you. I've only been here about 4 to 5 months.
Okay, that is very new.
Very new. But I've worked in ENT over at the hospital with Dr. Byrd and the team
Okay.
prior to working over to the Cancer Center.
Okay. All right. So what kind of drew you to this career? Talk about a little bit about your passion for this career, and also a little bit about what a nurse navigator does.
I'll go first. I'm not going to put you on the spot. My take on a nurse navigator is just to navigate the patients and their family from the beginning of the process throughout the whole process, to be there, the liaison between them and the doctors and any testing or anything that they may need. And my reason for being in this area is because I think I have a love for helping people, I have a love for people, and I feel like I'm able to use all of that here at the Cancer Center with these cancer patients and their families.
Okay. Great. Well, we're glad to have you here.
Thank you.
Barb, what about you?
Well, I had been in management for many years over in the ENT clinic, and when the opportunity came when the navigator started being hired, it was very new, I said, this would be a great way for me to get back closer to the patients.
Okay.
And be more involved. And I already knew head and neck and ENT, so it was easy transition for me to come over here. And I really, really enjoy the camaraderie we have as a team. We really do work as a team over here. And like LaJuana said, we, as a navigator, we are that first point of contact for the patient, new patients coming in. And we do try to establish a relationship with that patient and the family, so we're that go-to, that person, that common denominator for that patient.
So if they have questions, they call you, and then you navigate them to wherever they need to go.
Exactly.
All right. Sarah, let's talk a little about you. I know that we have had you on a previous episode of A Cancer Conversation, but talk about your role, how you got started in nutrition and diet and that sort of work.
Right. So starting, my teenage years, I was fairly athletic, played soccer, basketball, and we had a dietitian come to our soccer team to talk a little bit about nutrition, and I was just really intrigued by the relationship between, athletics and nutrition. So I took a couple of nutrition classes in undergrad, and it was kind of history from there.
Okay.
Went on, and since I've been over here, I actually started on the inpatient side.
Okay.
I worked a couple of years and had worked with oncology patients. And again, kind of like Barb, got the opportunity, the cancer center arrived, and that was 2012. So about 10 years been at the cancer center, and really enjoy it over here.
Okay. All right. Well, great. So now let's transition a little bit talking about head and neck cancers and nutrition. Sarah, are there specific diagnoses or types of patients that are often referred to you by Barb and LaJuana when it comes to head and neck cancer patients?
Right, yes. I would say anybody that has a cancer involving the oral cavity, oropharyngeal, nasopharyngeal, are going to have, are at higher risk for having swallowing, chewing difficulties, treatment-related side effects. So they're going to be impacted at a much higher rate than other diagnoses. So those are typically the ones that want to get early start on, early on in diagnosis and treatment as far as nutrition intervention.
Okay. So what challenges or symptoms do the two of you see, notice, recognize in cancer patients, in head and neck cancer patients, and you see those symptoms, those challenges, and then decide to bring in Sarah or her colleague Rachel, who's also on the dietitian team?
The biggest one, I think, and please correct me if I'm wrong, is when a patient has a PEG tube placed, which is the stomach gastrostomy tube.
Okay.
And that means already that they're anticipating swallowing problems after surgery, after radiation, and so we immediately try to get Sarah or Rachel involved so they can teach that patient about the tube, how to do the feedings, and that kind of thing.
Okay.
And we have other, patients that go in through radiation that we anticipate there's probably swallowing problems. Some people come with swallowing problems, but with head and neck cancer, at some point they're probably going to experience it.
Okay. All right. Why is it so you talked about being involved early on, Sarah. Why is it so important for you and for the two of you, LaJuana and Barb, to have that early involvement from the dietitian team when it comes to head and neck cancer patients?
To prevent them from getting into a situation where they're have lost a massive amount of weight, and then that may even require another hospitalization, because we want them home with their families. So that's a big thing that sticks out of my mind is, you want to get early intervention to prevent them from getting this to a more serious situation.
Okay.
Right. Yeah, and I would echo on that. Malnutrition early on, especially what we call sarcopenia, which is basically just muscle mass wasting, has been associated with poorer outcomes. And I would say too, nutrition intervention can help minimize treatment interruptions. So if patients can, keep their weight up, keep swallowing, be able to tolerate an oral diet, or even use their feeding tube should they have one, they're going to lose less weight and do better and complete their treatment course at in a timely manner.
And just to add to that, patients, if you know that they've got poor nutritional status to start with, it's a great time to bring the dietitians in to get their body built up, because they're not going to heal well after surgery if they don't have a good nutritional base. They've got to, some people come in and they're already wasting away, and they've got to, bulk up and build up before they can be, taken to surgery.
Let's talk a little bit more about that. I like that you brought that up. Let's dive into that a little bit more. So at the Georgia Cancer Center, we always tell everyone that we don't just treat a person's cancer, we treat the whole person, because we know that the cancer is just a part of their treatment plan, how it's going to impact them when it comes to nutrition. Talk a little bit about how you approach those sorts of situations where you have to talk to a patient, not just about they're going to have surgery, or they're going to need chemotherapy, or they're going to need radiation and what that's going to look like, but also looking at things like nutrition, weight loss, and getting ready to even be able to undergo those sorts of treatments?
Well, I know initially when they come in for their initial consultation, the doctor usually goes over everything as far as the plan of care, as far as the treatment and all those things. And I know I usually try to talk to the patient afterwards and let them know, okay, so before we start this process, just be mindful that you may incur some weight loss. So let's go ahead and maybe try to start increasing your nutritional intake. If you're able to do that on your own, I also offer them, if they need to speak to one of our nutritionists, we can make that referral, but just kind of mention to them that they need to try to maybe increase their nutritional intake so they can be prepared for surgery or for whatever treatment plan that they're maybe facing.
Okay.
Yeah. Usually pretty straightforward with patients too. I mean, a lot of the reasons we eat are for pleasure, for fun, social. A lot of that is affected with head and neck cancer treatment. So treating eating more as an obligation and out of necessity, and kind of changing your mindset of, I'm going to eat because something tastes good. Well, it may no longer taste good once you're getting radiation or chemo. So, just kind of approaching that and educating the patient early on so they know what to expect usually helps them as they go throughout treatment.
All right. Well, I appreciate the three of you joining me for this segment, for this discussion, and we look forward to talking to you all next time. And remember to like and subscribe. You can watch us on YouTube, and you can also find us on Apple Podcasts. So thank you very much for joining us today.
Thank you.
Thank you.